We're going to take a look at a case of acute pulmonary embolism on CT. This is a CT of the chest with a pulmonary embolism protocol. The way I know that is because most of the contrast is opacifying the pulmonary artery. That's the vessel that's brightest. Compare that to the ascending aorta here, also opacified but not quite as well. And what I'm looking for is a filling defect, so an area where the pulmonary arteries are not opacified because there's a clot occupying that space. And right away, when we follow the main pulmonary artery to its branch point, we see there's this filling defect draped over the bifurcation and extending into both main stem pulmonary arteries. Here's the left. You can see it's even extending more distally into the lobar and segmental branches. We follow the right main pulmonary artery. This is all clot. You even see some down here. So this is a fairly large pulmonary embolism. In fact, when we see an embolism straddling the bifurcation like this, we call that a saddle pulmonary embolism. When we see a PE of any kind, there are a few things you want to keep in mind. Number one, is there any evidence of right heart strain? So is pressure increasing on the right side of the heart to the point where the right heart is having difficulty overcoming that pressure? One of the ways you can look at this is scroll down to the level of the ventricles. Here we have our right ventricle anteriorly and our left ventricle. The left ventricle should be bigger than the right ventricle. At least they should be about the same diameter. You can see here the right ventricle is significantly dilated compared to the left. And our interventricular septum here is actually pushed to the left. Normally it should be the opposite, where you have a slight curvature towards the right ventricle. But in this case, the pressure is so high in the right ventricle because of those emboli that it's causing strain and pressure pushing the interventricular septum towards the left. So in this case, I would say there is right heart strain. Something else that you can see in PE is pulmonary infarct. So when you deprive blood flow to the lungs, the parenchyma can die. And the way to look for that is go to your lung windows. What you should see are peripheral areas of ground glass, or what's typically described as a bubbly appearance. We don't see that here. There's some atelectasis. The patient isn't taking in a full deep breath for this study, and so that's normal. But we don't see any of those areas you might expect if there's a pulmonary infarct. The reason for that is because this is probably pretty early. It can take a little while for the pulmonary infarct to develop. So even though we have right heart strain in this case, we don't have findings of pulmonary infarct. So in summary, key points for pulmonary embolism is you want to describe where it is. Is it central or is it peripheral? Overall, that tells you how bad it is. Then you want to evaluate for signs of right heart strain and then pulmonary infarct on your lung windows.